Thanks very much. So it's a great pleasure to come and speak to you today. This has been an area of interest of mine since my fellowship, hamstring injuries, and I'm going to discuss the role of surgical management of hamstring injuries. So this might be a very short talk indeed. But when you consider the role of surgical management with hamstrings, I often heard orthopaedic surgeons who look after hamstring injuries were described as being like undescended testicles. They're very difficult to find and pretty useless when you find them. And the reason why people don't look after hamstring injuries because they're difficult. So knee surgeons say, no, that's the domain of the hip surgeon. The hip surgeon said that's the domain of the knee surgeon. So as a hip and knee surgeon, I'm kind of caught in between two stools, so you're almost forced to look after them. So it is an area that's not very well known, in surgery, and not many people do it. But it is a very interesting area, and I think patients can do well in the right circumstances. So first question, is there a role for surgery in hamstring injuries? So yeah, who knows? There may be some role. It's certainly not as big as some people would claim, but there is a certain small indication for surgical intervention. So in my talk, I want to discover when there is a role, so in what circumstances, why you are required to do surgery with hamstring injuries, how we do the surgery. So I'm just going to touch particularly on intratendinous injury, as Nick had asked me to do, but also on the more common injuries that we see from a surgical perspective, which is the proximal hamstring rupture. So I'll just talk a little bit about that. And also, so what happens when we do surgery? What are the results? What are the outcome or the prognosis you'd expect from patients, and what you do after surgery. So, the importance in terms of opening up the discourse between surgeons and people who are responsible for the rehabilitation is really important. So we speak the same language and we know exactly what each other is doing. So first of all, I want to go back to basics. I know we've already touched on anatomy, but when I was looking into the proximal hamstring, my original remit as a fellow when I was in Vail, Colorado, was to look at the anatomy of the hip. So we looked at the arthroscopic anatomy, and then we decided to kind of look to the back of the hip and realized that not many people had described properly or qualitatively and quantitatively the anatomy of the proximal hamstrings. So I went looking in the literature to see what the anatomy was, and I was dumbfounded to find that a lot of the anatomy described in the literature was actually incorrect. So you had these diagrams that put the long head of biceps as the most lateral structure and the semimembranosus as more medial, and it's kind of what you'd expect considering that semimembranosus is a medial structure, but when you look proximally, it's not that way at all. So we had the advantage of having these cadavers available to us, and most of them were just the hemipelvis, but I was able to get access to a full length, and this is one of the dissections we did. So we're just going to go through it for a minute because it's quite important just to visualize exactly what's going on. So here, just where this forceps is, this is a semimembranosus. So you can see exactly why it's called a semimembranosus. It's a very long membranous portion to the tendon. And we've seen with Tom and his diagrams how that can be injured through its entire length. But you see the way it goes under the long head of biceps and attaches medially. And then we have the long head of biceps, which comes up here, and I'll show some further images. And this attaches here in what is the conjoint tendon, and this fuses with the semitendinosus at this point here. So this just gives an idea of the structural anatomy that we actually deal with. And you'll be surprised how poorly this is understood by surgeons, which is quite shocking, and it's most of the surgical diagrams which are incorrect. So it's interesting, when we looked into this, we found an article that they were talking about doing endoscopic hamstring repairs. Now, the thing is bloody difficult enough when it's open, but to stick a camera in and do it endoscopically is very, very difficult. And in their diagram, they actually got it incorrect. So we wrote a letter to the paper, and we didn't want to be smug, but we decided, well, your actual diagram is mislabeled. And they came back and said, no, it's not mislabeled, and you're incorrect. So it's funny, you're dealing with surgeons, they can be occasionally a little bit arrogant. So I'm sure you won't agree with that. So we'll look just a bit more close up, and this shows the proximity of the sciatic nerve. So this is the lateral side. So you see the sciatic nerve here. So it's pretty close. That's probably another reason why people aren't too keen on operating on these, because you've got this it's tiger country around this area. So you can see here, this is the sciatic nerve. This is your semimembranosus, and this is your conjoint tendon. So for me, the conjoint tendon is actually just really the long head of biceps tendon, and we'll show further why this is the case. So just looking at the medial side, so we get a good idea. So this is where the semimembranosus comes off at this point here. And you can see the nice tendinous portion of the long head of biceps just more posterior to that. And there's your sciatic nerve. And then we see where the semitendinosus attaches. So when we were doing this, there's a couple of interesting findings we found. So the semitendinosus really doesn't attach as a tendon. It attaches as a muscular attachment. So when this tears off, when you're all three hamstrings are avulsed, you don't really reattach the semitendinosus tendon because the tendon doesn't exist. It's just a muscular attachment. So it's really just long head of biceps, and wherever those muscles fuse together, that just goes back en masse, and then the semimembranosus goes back individually as well. So this is another interesting thing, and this touches on what Tom says in terms of, this is a really critical thing in terms of what are the indications for surgical repair of the long head of biceps. So this diagram shows us, or this clinical picture shows us the long head of biceps. So we've just taken it off at its origin, and we look at the tendinous portion. So how long is the tendinous portion? So it's roughly around 9.5 centimeters at this point. So anything below that is like, it's really difficult to repair because it's like stitching a fillet steak. You're not going to get any suture material to grab. So this is where you're looking to do surgical repairs if there are tendinous portions, particularly in the long head of biceps. So for semimembranosus tears, I'll show you some clinical examples later on, but they're much more rare. They don't occur very often. There's a long tendinous portion of those. But for long-headed biceps, which has been shown to be the most common, it's really only within this region would you consider repairing them. And a lot of the tears occur more at the muscular tendinous junction, so it's a bit more difficult when it gets more distal to actually affect a good repair. So this is important, and I'll reference this a little bit later. So when is there a role for surgery? So there are certain circumstances where surgery is certainly indicated, and there's the black and white areas, so we'll go through those. So the black and white, so you have a rupture of the origin. So you have either an isolated tendon, which could be long head of biceps, or semimembranosus, or commonly you get that both tendons are avulsed. So the conjoint tendon, which is long head, and then the semimembranosus. So in that circumstance where they're completely off in a young person or even a more middle-aged person, you would certainly go in and try to repair them because they come in with considerable pain initially, which is expected, but then loss of function and power, which is very important. So to give them a good functional result, I would certainly advocate repairing those ones. In terms of a distal tendon avulsion, so you see this not very commonly, but you get a biceps femoris which comes off around the fibular head, or where it comes around the proximal and the anterolateral aspect of the tibia. They're ones you would certainly go and try to repair. And you often see those in the more chronic case. You get the snapping tendon around, so they can be effectively repaired with suture anchors. So then we go to the more grey area, and this really encompasses most of hamstring repairs, unfortunately. So we look at tendinopathies, and that's not something I'm going to touch on hugely, but it is something in the literature that you see quite often. So that's either an isolated tendinopathy of semimembranosus commonly, but also you get the tendinopathies of both tendons. And this is the main subject I'm going to touch on today, is the muscular tendinous junction injuries. So we look at the high-grade ruptures, and then also importantly is the recurrent injuries. So most of the case series, which I'll touch on a bit later, is that they look at recurrent injuries. So it's not the first time that people have tried the rehabilitation, prolonged rehabilitation typically, and they go back and they re-injure. So these are the more chronic cases which are often come to us for surgical repair. And then we look at the elite athletes. So if you have a weekend warrior with a high-grade injury, you typically would, even if there's some degree of retraction, they typically would persevere. They don't come to us very often, but you'd persevere potentially with a non-operative course. But for elite athletes, there's a greater pressure to go in earlier because obviously the impact of being out of sport for longer in terms of monetary terms and for the team is higher. So why is there a role for surgery? So the role for surgery when you've lost a tether. So if you consider that your hamstring is spans two joints, so it spans your hip and your knee. So it has a huge function. If you've lost your tether, your proximal tether, you're not going to be able to contract that muscle with any degree of force. So that's really why we go in and do it. In the more chronic setting, you do it because they've persistent pain and they can't get back to a good level of function, and they don't have the same degree of power later on. And we've shown there has been shown that these patients go on to have decreased power and more injuries later on. So that's why there's a role for surgery, is to try to repair these very ballistic type injuries, but also to try to improve the function of those injuries that are recurrent. So this just gives a previous example. So if you've lost a tether of a muscle, it's not going to function properly. So if you pulled it off at the origin, it's never going to go back. It's like an Achilles tendon. If that's pulled and you don't rehabilitate that or get the two ends to fuse together, it's not going to function well. So that's why there's a role for surgery, if it's not going to heal in itself. So also, this is a great quote from Einstein, which said the definition of madness is doing the same thing over and over again and expecting different results. So this is really encompasses the chronic setting and why you would do surgery, because there's no point in going through a prolonged rehabilitation if you're only going to rupture it again. So that's why there's a role for surgery in those chronic cases. So how do we do it? So first of all, I want you to visualize. We're all into sports and psychology now. It's about visualization. So I want you to imagine that you're in a deep, dark hole, okay? And there's something at the furthest extent of your reach, say $1 that you're trying to get. And it's at the furthest extent of your reach. But every time you try to reach that $1, the wall closes in on you, okay? And not alone, every time you try to reach it, the wall closes in, but there's a big electric cable beside you to electrocute you at every stage. So this is essentially like doing surgery on the hamstring. So it's literally and metaphorically a pain in the arse. You've got your assistants hate it, your anaesthetists hate it, because you've got a patient in a prone position. The assistants are pulling a big gluteus maximus out of the way, often a fairly robust buttock as well, and they're tired. So every time you go to just get the hamstring, get that suture in, they lose concentration and everything closes in. In a lot of circumstances where you've got a lot of scar tissue, it's hard to distinguish between the sciatic nerve and what's the semimembranosus. So it's a sphincter tightening surgery is what we describe it as, and you often find you sweat more for this surgery than any other surgery. So that's probably a primary reason why people don't do it, because it's very difficult, and also the complication rates are very high as well. If you consider you're working in a fairly dirty area, and your risks of infection are significantly higher than other types of surgery, and also because it's a dependent area. So we're all sitting on our backsides, some more often than others, and it's dependent. So all the clot that forms when you do surgery goes right to the wound. So I typically tell patients that it's almost a 5 to 10% infection risk. Now you always hedge your bets. If you don't get infected, they think you're a hero, but it is a higher rate of infection, and we do have to wash these out occasionally for recurrent infection. So it's not, we don't go into surgery willy-nilly. We really have to go in for a good reason, because the complications are quite high. Okay, so last time I put up a picture of the buttocks, I got in trouble because I used a female buttocks. So I'm going to use male buttocks now to describe the anatomy. So this is purely for surface anatomy reasons. So when we're doing surgery, we have to get access. So you see the gluteus maximus is in our way. So we want to get into the ischium, where this is predominantly for proximal hamstring injuries, but also for tenderness injuries, which are very high. You have to get underneath the glute. And to get underneath the glute, you have to make a skin incision. So the skin around this area typically stretches. So we obviously try to be as cosmetic as possible, but you don't want to affect your ability to get access by just doing a nice incision. So we have to be conscious of what type of tear we have in terms of what type of incision we do. So the buttocks have this gluteal crease. So if it's a very high injury and it's not much retraction, we can normally get access by making a transverse incision, and we get under the glute. So the glute comes down. We have to get our assistant to retract it, and then we identify the ischium. So the ischium is always the area which is your surface landmark. But in that area, it can be confusing around that area. And I've seen a case when I was in America where they actually attached the hamstring back to the lesser tuberosity. Because they're so close together. Now you think it would never happen, but when you're in there, they're only a few centimeters apart. Obviously that patient didn't do very well. So when we're making the incision for tendons that haven't retracted too much, it's a transverse incision. But when we're doing a more proximal tenderness injury and we don't know how distal we need to go, we would typically err for a more longitudinal incision, but they don't heal very well. And also the other considerations you have to take into account are the fact that you have a nerve which supplies the posterior aspect of the thigh called your lateral cutaneous nerve of the thigh, the posterior lateral cutaneous nerve of the thigh, and that can typically get injured, particularly when you do a longitudinal incision. So it all sounds very appealing work that you're going to give someone a pain in the arse and a numb leg after surgery. So it's this is what we typically use if we have any suggestion that a tendon has retracted. So in those very explosive injuries, the sprinters where it's a tendonous injury, we typically err for longitudinal because we don't know how distal we'd have to go. Okay. So I'm just going to touch on the proximal hamstring avulsion first and just give you some examples of what we do surgically for that. So as I mentioned previously, this is a ballistic injury. So it's like a grenade has gone off in the back of the leg. And you've all seen this in terms of the extent of the bruising. But it's the most typical reason, aside from sport, is people water skiing. So people who haven't done it, they try to pull the boat, not let the boat pull them, and their ski gets caught in the water, and then they tear off the hamstring. So it's normally men who are maybe think they're younger than they used to be and go back out in the water in their 40s, 50s, and they pull the hamstring off. So you also get the other type, which is the elite athlete, so the explosive athlete like the sprinter, and the explosive motion, they can pull the hamstring origin. So you see the size of the muscles you're dealing with, and they're so powerful, and a small tendon which is attached gets avulsed as a result. So you see this is an example of some of the bruising you might see, so you can get an idea of how vicious an injury that is. This is quite common when people come in and their leg is completely black all the way down to their ankle sometimes. So when we look at MRI scans, now they typically are very kind in radiology. They make these T2 images and for orthopedic surgeons to be able to understand them. And anything that shows up as white is fluid. So that's typically our extent of our radiological nous is to understand this. So we just follow where the white stuff goes, and we can see little black strands. So the asterisk there is the tendon, but you see the extent of the hematoma when you're looking at this. So for these injuries, these are actually not too bad because it's very easy to identify where the injury is. You just open the skin and it's like a geyser. All the blood and hematoma will rush out, and you put your finger right down to feel the ischium, which is bald, there's nothing attached to it, and then the tendon kind of approaches like almost like a mushroom coming out of the wound. So you can see here, so this is the tendinous ends, so you can pull it right out of the wound, and we typically just place anchors in the ischium, and we can reattach it back on. So the number of anchors is dependent on surgeon choice. There have been a number of studies which have looked at it. We try to put them back in their anatomical position. And so just an example here, this is where the semimembranosus attaches. So it's kind of like an oval shape. And then this is where the conjoint tendon attaches. And then this here is where the muscle area of the semitendinosus attaches. So we don't really worry about that. We just try to get the two tendons back as anatomical as possible. So there's been studies looking at how many anchors you need to use. It's not really that important. This was sponsored by industry, so the more the merrier. So the more you put in, the higher the pull-out strength. But typically it's based on the size of the individual. When we put the anchors into bone, we can either use what's like a corkscrew anchor that you can use, it's titanium, or all suture anchors. And what my test is, when you put it into the ischium, you should be able to pull the patient off the bed by holding the anchor, because the forces going through that are huge. So if you can't do that, if your anchor pulls out, it means it's going to fail. So you really have a huge strength in the tissue. It's also important, you might need more in those elderly patients who have tendinopathy, because the quality of the tissue is poor. So you also have to consider you might need to reinforce it with different suture techniques. But that's more technical stuff, but really that just gives you an idea of what we do when we're repairing these. So now I'm just going to go through a few examples. I think this is what Nick had asked me to speak about, was just some more of the intratendinous examples. So just before I start, this is a very much a multidisciplinary approach to doing these, because a lot of times the physiotherapists would see the patient, they'd refer for MRI scan, The sports medicine physician also is involved, and then it comes to us for an opinion as to whether they require surgical intervention or not. So, in terms of reading this, it's important to have a good liaison with your radiologist in terms of going through it together to look at the tendon, because it's not always very obvious, and sometimes it takes a bit of consideration in terms of whether you should operate or not. From our perspective, from a clinical perspective, we're looking at the degree of strength loss as well, and also the timing of the injury. That if someone comes to you at 6 weeks, or even 4 weeks, it's quite difficult to do surgery at that stage, because the tissue is like wet chewing gum. It's not going to take a suture very well. You're better off either doing them very early or in the more chronic situation, because it's just the surgery becomes more difficult. So here's a case example of long-headed biceps. So once again, we just follow the white, so we see the tendinous tear there, and we're looking at the distance we have from the ischium. So within our 9.5 kind of centimeter, and you can err, that's not the same across the board. You look at the structure of the tendon, whether you see any waviness, or I know it was mentioned by Tom, in terms of that concertina effect you see in the tendon, to see if it has lost some of its tether more proximally. And they're the ones that would typically benefit from surgical intervention. So this is just to emphasize the anatomical importance of the 9.5 centimeters. So then we just look at the repair. So this is obviously done through a longitudinal incision. So the head is up here, so it's in the same orientation as the MRI. So you can see here where we've gone through the muscle belly, and you see the two tendinous ends. So in this circumstance, it's hard to imagine this is going to heal in one nice tendinous continuity. But if there is a good scaffold, I think was the word Tom mentioned, that you would leave it. But if it's all tethered and it's retracted, it's probably going to benefit more in terms of being repaired. At least it puts everything back together to allow it heal in the more anatomical fashion, and therefore you'd hope it would have less risk of re-rupture in the future. So this just gives you an example of when it's repaired. So it's very small tissue. It's very small suture material we use. It's not very heavy duty. It's absorbable suture, and it's really just it's only very, very small. So the strength of the suture itself is not that high. It's just the fact that you're realigning all the fibers to allow it to heal in a good position. So that's really the idea. So this just gives just another couple of examples of ones that you would look for surgical repairs. You see that this end here is just floating in the breeze, and it's not really attached to anything. So you really want to orientate that and just approximate it to another tendon's end. And here's another example here where you can see the two ends of the tendon, and that you orientate them. But these are difficult to find. So when you go in, you often, with particularly the muscle belly of the semitendinosus, if it's not right at that tendinous portion, you have to go through the muscle, or you have to go around the muscle to find the tendon. So sometimes you look in and you say, what the hell are we doing here? I can't see any injury. So you have to be patient and follow your MRI as a guide to look where the tendinous portion is, because it's not always very obvious at first glance. So I'm just going to touch on the chronic tear as well. So I think this is a very similar image, or it may even be the same image that Tom had up, but you can see this kind of longitudinal split. So this is in the more chronic setting, where you see the two sides of the tendon, and there's this recurrent chronic injury. So when we look at this from a surgical perspective, this is what you actually see. So it does correlate nicely with the MRI pictures. You see the two sides of the tendon. So they just have healed with scar tissue, but they haven't healed up. So it looks pretty innocuous, but this is something that's preventing someone getting back to sprinting at their high level and giving them constant pain. So it's really a very simple case of just reapproximate. So you see very clearly there the two sides, so it's kind of delaminated, and we really just stitch that back up together. So make those when two become one. I think that's a Spice Girls song. So you just make that into a single tendon there. So that's kind of a good example, I think, of a chronic tear and how it's repaired. Tom mentioned about the frequency of the injuries, and semimembranosus tears are much rarer. We don't see them as often. But when you do see them, they're quite impressive in terms of how much tendon has been injured, and because of the length of the tendon. So you see here, you can see that the tendon, one tendon end. So we follow the white stuff, and you see that there's tendon here, and you give the impression that there's it's not as taut. There's a bit of kind of concertina effect of this tendon here. And then I've shown you a few images. You can see how there's also signal coming from more proximally as well. And we can see further down on the image how this really runs a pretty long length of the semimembranosus. So in this circumstance, if you are making a decision for this, you have to be forewarned as forearmed. You certainly wouldn't do a transverse incision here because you want to potentially follow the length of the tendon down to try to repair how it's stripped and delaminated. So this could involve quite an extensive incision down the back of the leg, which is not the most cosmetically pleasing to the patient, but you want to repair all the tendon that's injured when you do have this circumstance. So you can see, you can get an idea of the length of the incision here, but this is an example here of one of the nerves. So that when you look at the sciatic nerve, which is right beside it, you do get branches that go to the muscle. So this is one of the branches of the sciatic nerve. So it's not for the faint-hearted when you're dealing with these nerves right beside you, and it's important. It's critical. It's the first stage of the operation is you're actually going in, identifying the nerve, and then you're identifying at the end of the surgery. So you're always a bit nervous when you wake the patient up. You want to make sure that they're moving that leg. And this shows you here that the tendinous portion, how it's stripped. So it's quite a big strip of tendon, and we'd repair that back as normal. So what? So does this work? Is this just giving us something to do? The problem with a lot of the literature on muscular tendinous repairs is there isn't any, or there's very little of it, and so we don't really have good long-term follow-ups on whether this works. So we know certainly from David's work that having a previous hamstring injury does reduce your power and your strength. So, for the most part, we definitely would try to rehabilitate a lot of hamstring injuries non-operatively, which makes way more sense initially. And it's only in the recurrent setting would you consider a surgical intervention. Peter Bruckner has written extensively on this, and David Connell, with being the radiologist, has looked at this, and it's nice to see the work is being continued in terms of the frequency of these injuries. But in Australia, we really have a huge experience in this area. You don't see the extent of this surgery internationally. The US or even in the UK, it's not done to the same extent, probably because how sports crazy particularly Victoria is. It's probably the real centre of hamstring surgical repair and also hamstring studies. But we know the importance of looking at these intermuscular tendon injuries, and this is a fantastic example or fantastic review of these strains and just show these injuries and shows how important they are to treat them appropriately. So I was trying to look at some examples of what prognosis you could give following surgical repair. And really, you only have a selection of case reports. So this is a report by Hayden Morris, where they looked at a conjoint tendon injury, biceps injury, and very similar to the examples I showed, but it's only a series N of 1. So you can't really take a huge amount from that. This is a very similar example to what we showed in terms of where the injury was. Then I found this surgeon from Lyon, Bertrand Sonnery-Coté. He looks after a lot of the high-level athletes within France. And he had a case series of his surgical management of all recurrent muscular tendinous injuries. And he found that they did well. These all had recurrent injuries after 3 months following their original injury, and they'd gone back to sport and had further problems, but only a series of 10 patients. So you can see how small the numbers are in terms of what we're looking at into follow-up. So we try to be as evidence-based as we can, but realistically, the evidence for this is poor. So most of this is only level 4 evidence, level 5 evidence at best. So we just want to take that into consideration. So the other important thing is what we do following surgery. So as surgeons, we have to stay in our lane. We're surgeons. We put things together. We're not that smart. We just get 2 ends of a tendon, we suture it. So, but we have guidelines, and we like to provide some guidelines in terms of how we rehabilitate. And the reason why we just want to protect our repair. So you guys are the experts in terms of the rehabilitation, and I think that's, as I said at the start, it's important that we can learn from you too, because you see the patients, you see the players, how they're responding to surgery. But the guidelines that we have are, I have to thank Julian Feller for all of these. That he taught me how to do this surgery, and he has done most of the surgery on the elite athletes in Victoria. But we have some guidelines in terms of the phases of healing and how quickly to progress to rehabilitation. So phase 1 in terms of healing, it's typically the healing phase. Phase 2 is the maturation phase, and phase 3 then we progress with further strengthening and getting back to normal level of function. So for hamstring avulsions, this is slightly slower than the end-to-end repairs, but we look at phase 1 is up to 6 weeks post-operatively. So you're really not doing a huge amount because you want to let that tendon heal to the bone. Phase 2 is between 6 and 12 weeks, and then phase 3 is after 12 weeks. So I'll go through the phases of what we recommend or what are their indications for surgical intervention, or for rehabilitation, sorry. The end-to-end tendon repair is quicker. So phase 1 is the healing process. Because you're putting those tendons back together, it gives you the best opportunity to heal, is up to 3 weeks. Phase 2 is between 3 and 6 weeks, so that's the maturation phase. And phase 3 is after 6 weeks post-operatively. So it's quite significantly quicker. It's almost 50% of the time of the hamstring avulsions. But nature doesn't discriminate, and that's the one thing you see. Oh, we have an elite athlete, and I know there was in the paper when was that Man United player had his ACL done and he's back at 4 months and he's looking at doing all these kicking these heavy bags, but nature doesn't know that he's a Premier League player as opposed to a weekend warrior. So you have to respect nature, respect that some people are going to heal quicker, some people are going to have a lot more inflammation post-operatively. So you have to take a lot of these phases or indications of rehabilitation with a degree with a pinch of salt, just to work on your individual athlete. So what we would recommend in phase 1 is weight bearing is tolerated. So immediately after surgery, we typically would give them crutches just for the early period, so they have some protection. Don't go beyond the limits of comfort. So particularly when you feel that stretch, it's like someone has an acute hamstring injury. You feel that stretch. You don't want to push through that stretch. You just that's your body telling you that your muscle fibers have shortened. So we don't want to push them through that, particularly with the repair. We let them get onto stationary bike when they're comfortable, so really when they can put their arse in the saddle. And you can walk in the water. So once the wound is healed, we're happy to get in the water. We typically use kind of Dermabond glues on the wounds now so that they're waterproof, so you can get people into the water a little bit quicker. But we're very conscious that you have to let the wound heal before you really progress, because any degree of increased inflammation or swelling in the area is going to give rise to problems. And that once you get an infection, this is all out the window. We encourage you to do double leg bridging and also do a lot of gluteal work, the gluteal activation in the initial setting. And they can do that just as soon as the injury happens as well. And then jogging as their pain allows. So it's not that much in terms of the phase 1. So that's up to 6 weeks with the avulsion and 3 weeks or thereabouts with the end-to-end repairs. In terms of phase 2, we progress from double to single leg bridge. That's what we recommend. Increase the speed of running as comfort allows, which will be so you'll get less tightness as they run. Light resisted hamstring curls, some lunging as tolerated, and then Nordic hamstring exercises with an exercise ball or TheraBand for support. So you guys will know much more about this than me, but these are just some of the indications that we like to give out. So then we go to phase 3. So phase 3 is really once the healing, the maturation has taken place, and then we progress to unrestricted running and strengthening as allowed. So there's no major science with it, it's just these are guidelines that we like to offer. Okay, so I can learn a lot more from you guys than you can from me on this aspect of things. So essentially that's the surgical approach to hamstrings. So I'm happy to take any questions you might have, and thank you very much.